For our case study, we got organ transplant. Our patient is Frank Smith. He's 43 years old. He weighs 76 kilograms. Some health history of Frank is he has uncontrolled hypertension, coronary artery disease, he's had 3 myocardial infarctions, he has progressive shortness of breath, and he has advancing right-sided heart failure. Frank has had a successful heart transplant surgery. We are told that Frank is on 3 medications: cyclosporin, tacrolimus, and methylprednisolone. 3 months after Frank's transplant, he started to have feelings of anxiety, decreased appetite, feelings of hopelessness, depressed feelings, and these feelings are affecting his ability to adhere to his medication regime, to engage in exercise, and to participate meaningfully in his family life. Mr. Smith does not want to take any pharmaceutical drugs for anxiety or his depressed feelings. He also expresses interest in more natural remedies.
With organ transplantation, there are both cell-mediated responses and antibody-mediated responses involved in our bodies. Regarding our patient Frank Smith, he is at risk for what is known as a type 4 hypersensitivity reaction, which is driven by T cells, macrophages, cytokines, and all the other cells involved in our innate and adaptive immune response. As well as CD4 and CD8 cells, a type 4 hypersensitivity reaction is usually known as a delayed hypersensitivity, as it appears several hours or days following a procedure, with respect to organ graft rejection. With every heart transplant, there is risk for rejection. There are 2 phases of delayed hypersensitivity reactions. They are called sensitization phase and elicitation phase. Sensitization phase is elicited when an antigen, also known as a foreign invader, crosses the first line of defense in the body, which is the mucous membranes and the skin, in which they travel all the way to the lymph nodes. These cells then transform into dendritic cells, which present the antigens to T helper cells for activation. This stimulates an adaptive immune response in the body. The second phase, elicitation, T cells are stimulated from exposure of the antigen. They want to attack the invader. The exposure then causes cytokines and chemokines to be released, thus activating the macrophages and other T cells involved in the immune response. So as you can see here, there will be a lot of inflammation going on with all the release of cytokines and macrophages, but we'll get into that into more detail later on. During transplantation, the heart goes through a lot of damage, and there are risks for infection, which causes the release of both damage-associated molecular patterns, also known as DAMPs, and pathogen-associated molecular patterns, also known as PAMPs. These molecules stimulate pattern recognition receptors, also known as PRRs. These PRRs will trigger dendritic cells, which lead to antigen-presenting cell maturation, co-stimulatory molecules, and cytokines for the inflammatory response. In this process, antigen-presenting cells of the donor undergo maturation and move into the lymph nodes of the recipient, where T cells will recognize and eventually differentiate into T helper cells. The maturation of these cells to the lymphoid tissue is induced by the pro-inflammatory signal interleukin-1. For antigen-specific T cell recognition to occur, there are 2 requirements. The first is that the complex constituted by the foreign MHC molecule peptide presented by the donor antigen-presenting cell is recognized by the T cell. Second, the donor antigen-presenting cell must provide efficient co-stimulatory signals and actively contribute to full T cell activation. In short, we need recognition and activation to occur. One of the most studied co-stimulatory pathways is the CD28 and the B7 pathway. Dendritic or antigen-presenting cells have the ability to present antigens to T cells and express high levels of co-stimulatory molecules known as B7 ligands, or CD86 and CD80 molecules. When the CD28 on the T cells bind with the B7 ligands on antigen-presenting cells, these co-stimulatory molecules send signals to the T cells. Signaling through CD28 lowers the threshold of T cell recognition, which promotes T cell proliferation, cytokine production, and differentiation. Activated CD4 cells differentiate into T helper cells such as T helper cell 1, T helper cell 2, and T helper cell 17, or into regulatory T cells. Dendritic cells express large amounts of interleukin 12 to activate naive T cells to differentiate into T helper cell 1. T helper cell 1 cells produce inflammatory cytokines such as interferon gamma, tumor necrosis factor, and interleukin 2, while T helper cell 17 secretes interleukin 17 to recruit neutrophils to the site. The interferon gamma released by T helper cell 1 stimulates the activation of monocytes or macrophages, which furthers the production of cytokines and chemokines for the ongoing inflammatory response, while the interleukin 2 promotes proliferation of other T cells. These interleukins activate CD8 cells, which will turn into cytotoxic cells and lyse the foreign cells. Cytotoxic cells release cytotoxic granules that contain mainly perforin and granenzyme B, whose entry to the target cells will trigger apoptosis. The tissue damage occurs due to the direct T cell mediated lysis of the graft cells, activation of accessory cells, and complement activation. This tissue damage will go to thrombosis and graft ischemia. Now we are going to go into more detail about the recognition phase. Allorecognition is when antigens will stimulate the immune response against a specific allograft, in this case, the heart graft. There are two recognizable pathways narrowing in on the antigen-presenting cells in the mechanism of rejection, known as the direct and indirect pathways. The direct pathway is the capability of T cells to directly recognize non-self MHC molecules that are present on the donor cell's surface. Furthermore, the indirect pathway explains the ability of T cells to identify donor MHC molecules that are both processed and presented as peptides by the self-MHC molecules. With the direct pathway, there is a stronger antigraft response against the transplant. While the indirect pathway is a slower and weaker immune response, this is due to the fact that the direct pathway has intact donor molecules. As mentioned before, MHC molecules have a huge impact on the body's immune response against the foreign graft. With many HLA combinations in various individuals, it is unlikely that any two humans will have the same MHC antigens. The particular T cell recognition of an antigen contains cell surface markers on antigen-presenting cells and MHC molecules. The antigen is processed by the antigen-presenting cell, and the epitope is then placed on the antigen-presenting cell's surface. T cells recognize this and go through two different pathways to eliminate the foreign bodies. The different pathways have to do with whether the cell has an MHC1 or an MHC2 molecule. The class 1 MHC molecule is found on nucleated body cells and is recognized by CD8 cells, or cytotoxic T cells. In short, once these cytotoxic cells are activated, they will attack and lyse the cells that are seen as non-self. As for the class 2 MHC molecule, it is found on antigen-presenting cells and is seen by the CD4 T helper cells. CD4 cells are responsible for communicating with other T cells and B cells to initiate an immune response. So as mentioned above, now that we talked about the recognition part, we can get into the activation part, which is mentioned, which is the co-stimulation and the release of all the interleukins and the cytokines, which causes the inflammation and the graft ischemia and vessel thrombosis. As seen in this diagram, you can see that with the direct pathway, there is an antigen-presenting cell in the graft. And with the class 1 MHC molecule, the CD8 will recognize this, and then it will proliferate into a cytotoxic T cells. And then the cytotoxic T cells will go and lyse the cells of the graft and cause graft ischemia and inflammation. Also, with the class 2 MHC molecule in the diagram, you can see that the CD4 cell recognizes it, and then it turns into CD4 helper T cells. The CD4 helper T cells can then stimulate interferon gamma, which will activate the macrophages so that they can go after the foreign antigens. For the indirect pathway, we can see that it is the recipient's antigen-presenting cell, and the CD4 will recognize that, and then again it will turn into CD4 helper T cells, and then it can either release interferon gamma, or it can go to the B lymphocytes, which will be going after the antibody-mediated response. Now, since all this information is a lot, there are some helpful reminders and analogies that we can use. So we use this thing called a war analogy. So the antigen-presenting cells, you bring body parts to the T cells. so body parts throughout the whole war. And the T cells are the warriors, or the fighters, which you can call them, because they are the ones that attack. And the T helper cells are the communicators in this process. So we also have a basketball analogy. So in this case, the helper T cells are like the defense on a basketball team. They don't shoot, or in this case kill, but they help the team. So instead, they get the macrophages, which are the offense, to beat the other team, in this case, the foreign invaders.
There are different types of grafts that can be transplanted in humans. First, there is autograft, which is taking a piece of your own body parts and moving it to different location. For example, moving vasculature from the leg and using it for the heart. Second, there is syngeneic, which is a graft between genetically identical human beings. With these two grafts, you don't have to worry about rejection because they have your own cells or identically similar cells. Thirdly, there is allograft, which is the most common and most challenging. It is from one individual to another within the same species. While cross-matching is done to provide the most efficient outcomes, it cannot always be promised. This is the graft Mr. Smith has received. Lastly, there is xenogeneric, which is from one species to another. For example, a pig heart valve placed into a human heart. There are 3 types of allograft rejection after a transplantation procedure. This includes hyperacute, acute, and chronic rejection. In regard to hyperacute rejection, this type of rejection is known to occur several minutes post-surgery with vascularized grafts. This develops because of the presence of anti-donor antibodies that are already in the recipient before surgery. The antibodies then activate endothelial cells to secrete a coagulant factor which causes clotting in the blood vessels. Due to vessel thrombosis resulting in graft loss, it causes the rejections to happen very quickly in the body. Usually this can be avoided by checking the recipient and donor ABO compatibility for HLA antibodies. The most common type, acute rejection, occurs either 1 week or months following the transplant. This type is due to the body's immune system fighting the foreign antigens through either A, T-cell dependent process that corresponds to acute cellular rejection, or B, B-cell dependent process that corresponds to acute humoral rejection. While it is predominantly T-cell mediated, 15% is humoral mediated or antibody mediated responses. The B cells may either produce antibodies against the foreign antigen or promote even more T-cell proliferation. And lastly, chronic rejection occurs through cellular or humoral mechanisms in respect to memory cells and antibodies. It shows many types of prolonged tissue damage, such as fibroblast and collagen activity, leading to a lot of scar tissue in the body, which essentially leads to fibrosis and graft ischemia. While this type of rejection is usually caused by the humoral immune response, cardiac allograft vasculopathy, also known as CAV, is also thought to be a non-immune factor. CAV is the occlusive narrowing of coronary vessels. While chronic rejection is a slow process during the first 12 months after heart transplantation, the most coronary artery intramural thickening happens. In the case of Mr. Smith, he may possibly be at risk for acute rejection due to the fact that after 3 months he started to get concerned about rejection and taking his anti-rejection medication. With acute ejection being months after and mediated by T cells, it is the rejection he should be most at risk for. Aside from the 3 different types of organ rejection, there is a condition that may occur after an allograft transplant known as graft versus host disease. This should not be confused with organ rejection, as it is when the donor's immune system's white blood cells reject the recipient. In short, the donor T cells in the graft are going to attack the recipient because they see them as non-self. In a way, it is the opposite response of what occurs when the recipient attacks the donor cells. It is a very intense inflammatory response, thus causing detrimental harm to the host involved. The most common is the transplantation of hematopoietic stem cells and bone marrow transplant patients. In order for the development of GVHD to occur, the graft has to contain competent immunological cells and host must be incapable of having a strong immune response against the graft. And the host must have transplant alloantigens that are lacking in the donor graft so that the host actually appears foreign to the graft. Therefore, the graft is essentially attacking the host. With chronic GVHD, it occurs later on after transplantation, approximately 3 months after, and may affect many body systems. With chronic, symptoms usually include erythema, maculopapular rash, profuse diarrhea, or cholestatic liver disease, and affect tissue such as the skin, mouth, eyes, liver, and lungs. As for acute, it can occur anywhere between the time of transplantation to 3 months. While the symptoms appear similar in both chronic and acute GVHD, the chronic form is essentially more intense and widespread systematically throughout the body.
Common symptoms in organ graft rejection include showing physical signs of congestion, palpitations, change in heart rate, moderate dyspnea, and cardiogenic shock, which means your heart is not pumping enough blood that your body requires. Majority of patients showed preserved left ventricular ejection fraction, and the clinical presentation of some patients shows they are depressed. When looking at lab values in patients who are undergoing organ rejection, we look at the complete blood count, troponin levels, and electrolytes in the patient. In the complete blood count values, we will see a drop in white blood cell, red blood cell, and platelet count. This is known as pancytopenia. This can occur due to the intake of immunosuppressants. Troponin levels in the blood will also change during rejection. Cardiac troponin concentrations are significantly higher for 1 to 3 months post-transplantation. This is because of perioperative ischemia and injury. Another value we will see change in organ rejection is our electrolyte levels. Hyperkalemia, which is a potassium level that is higher than normal in your blood, is common in renal transplant recipients due to the post-transplant medications used. Hyperkalemia makes the heart more susceptible to arrhythmias due to the shortening of the duration of the action potential. Calcium levels in the body can also rise, causing hypercalcemia. Hereditary hyperparathyroidism prior to transplant, which is an excessive secretion of parathyroid hormone, is a common cause of hypercalcemia after transplantation. Metabolic acidosis, which is when the body produces too much acid, is also not an uncommon finding in transplantation. Cyclosporin and tacrolimus can produce metabolic acidosis, which our patient Frank is taking both of those immunosuppressants. After a heart transplant, additional studies such as endomyocardial biopsy, right heart catheterization, and coronary angiography are frequently performed. So why might rejection occur in Mr. Smith? Major differences in MHC complexes, which means the body recognizing it as non-self. Co-stimulatory pathway means lots of inflammation. His body might not be recognizing the new cells, or the immunosuppressants may not be inhibiting his immune response properly.
This slide is a good sum up of the way that immunosuppressant drugs, in this case corticosteroids and calcineurin inhibitors, work and their mechanisms of actions in blocking factors that are necessary for the action of T and B cells. For the most effective immunosuppressive therapy, one calcineurin inhibitor must be taken with one glucocorticoid. Cyclosporin and tacrolimus are immunosuppressant drugs that work by inhibiting calcineurin, which in turn suppresses the production of interleukin-2, which is necessary for initiating T cell proliferation. The principal use for calcineurin inhibitors is the prevention of organ rejection in transplant recipients. These two immunosuppressant drugs act by binding to a protein molecule called cyclophilin, which will activate the suppression of calcineurin. Calcineurin is a key to promoting action of interleukin-2, which is necessary for initiating the proliferation of T and B cells of the immune system. Major side effects include nephrotoxicity, infection, hypertension, tumor, and hair growth. The use of cyclosporin with St. John's wort may cause decreased serum levels and organ rejections in transplant patients. In immunosuppressive therapy, it is important that one calcineurin inhibitor is prescribed along with one corticosteroid for optimum results. Where Mr. Smith has been prescribed tacrolimus and cyclosporin at the same time, I would suggest that his medication regime be changed because he should only be taking one or the other, not both concurrently. Corticoids act by blocking T-cell derived and APC-derived cytokine and cytokine expression via different mechanisms. After passive diffusion across the cell membrane, these drugs bind to intracellular glucocorticoid receptors, forming complexes that then translocate into the nucleus. These complexes interact with glucocorticoid responsive elements, resulting in altered transcription of various cytokines. High-dose steroids are typically administered intravenously in the preoperative period as part of the induction regime, followed by oral dose tapering, which is what Mr. Smith has been prescribed in this case. His dose is 7 milligrams orally once daily. Long-term adverse effects of glucocorticoids, and in this case methylprednisolone, include adrenal insufficiency, osteoporosis, glucose intolerance, myopathy, electrolyte imbalance, cataracts, and glaucoma, and peptic ulcerations, with concurrent use of NSAIDs, because as we know, they're pretty hard on your stomach.
So is methylprednisolone the right drug? A study was done on animals who suffered severe heart damage from cardiac arrest and was given both methylprednisolone and cyclosporin together to see if cardiac output can be preserved after spontaneous circulation. Because of the spontaneous circulation, it resulted in many problems such as organ damage. Significant left ventricular systolic and diastolic dysfunction during this period is also common and has been termed post-cardiac myocardial dysfunction, or PAMD for short. PAMD involves ischemia, reperfusion injury, activation of inflammatory cascade, and elevated levels of circulating catecholamines, all of which can worsen myocardial function. The drug was beneficial when working alone because both agents decrease inflammatory cytokine production. When used in conjunction, it was proven that there was a decrease in cardiac output while the placebo trial continued to increase. The study also found that the combination of cyclosporin and methylprednisolone did not reduce PAMD, which differs from other preclinical studies that demonstrated an improvement of post-cardiac arrest in treatment with cyclosporin. With Mr. Smith, we would want to reduce PAMD to his heart and to ensure proper healing. With all this being said, I believe that Mr. Smith should not be taking both drugs in combination. So why is drug level monitoring needed for cyclosporin and tacrolimus? 55% of the liver transplant centers give primary care providers guidance or protocols on how to monitor therapy after transplants, and the remaining percentage leads to less optimal outpatient care in long-term patients, which is crazy considering the nursing profession is all about providing the best care, when in reality that's not being done with such an invasive procedure. According to a study done on the improvement in immunosuppression therapy monitoring in organ transplant recipients, it observed the monitoring of many drugs including cyclosporin and tacrolimus. It said it's required for regulatory monitoring of immunosuppressant drugs, and there are certain guidelines a healthcare provider must follow. The study shows that there are a variety of improved outcomes when monitoring immunosuppressive therapy in patients, such as immunosuppressant adherence, better patient education, adverse drug effect monitoring, and cost savings. Each patient of the study received at least one immunosuppressant therapy drug, such as tacrolimus and cyclosporin. and they did annual testing of immunosuppressant concentration and laboratory tests such as CBC, electrolytes, cholesterol panel, blood pressure, and glycosylated hemoglobin, which is what is deemed appropriate for immunosuppressant therapy. It was proven that there were more participants on tacrolimus that were meeting the monitoring recommendations than patients on cyclosporin. The study also showed that the participants meeting the recommended drug concentration level quicker by 51% were on tacrolimus, and cyclosporin only increased by 22%, and there was a greater need to monitor cyclosporin per month. With that being said, I would suggest that tacrolimus would be the best drug of choice over cyclosporin. Overall, the study believed that there were optimal immunosuppressant monitoring may lead to increased therapeutic range, early recognition of adverse effects, and improved chronic disease state management. So what is the difference between cyclosporin versus tacrolimus? Well, in a recent study explaining an issue warning from the FDA about new restrictions, contraindications, and dose limits for Zacor or zyfastatin, which is a statin. Statin-induced muscle injury and other severe clinical events such as liver injury and rhabdomyolysis. The study believed, when looking at cyclosporin, there was an implication that it was a major interacting medication requiring statin therapy to reduce hyperlipidemia and cardiovascular events. Currently, tacrolimus has replaced cyclosporin as the calcineurin inhibitor of choice in most immunosuppression protocols, and compared to cyclosporin, tacrolimus has very little interactions. If you choose to take cyclosporin, an additional low dose of simvastatin is necessary to avoid potential myopathy. Although tacrolimus is the better drug of choice, it has a high potency level compared to cyclosporin, so the drug monitoring is needed, but you can use simvastatin to better tolerate it. When observing the differences between the two drugs, the study split it into two separate trials. The first included 15 randomized patients or participants to tacrolimus and 17 randomized participants to cyclosporin, and on average all the participants were age 36. It was found that both groups had an increase of cholesterol, but a higher level of LDL in tacrolimus and a higher level of LDL2, which is worse, in cyclosporin. So tacrolimus was preferable. Overall, the study made it clear that tacrolimus is the better options. Now we transition of coping after organ transplant. There are many emotional challenges that can occur before and after an organ transplant. One factor is the waiting time for a new organ. Not only do some people have to wait several months or even years, but there would need to be so many interventions to keep a patient like Mr. Smith as healthy and comfortable as possible until he could get a new heart organ. Many organ transplant participants, such as in Mr. Smith's case, may experience difficulty or feeling as though they are taking the life of someone else and benefiting from it. This could be referred to a term as survivor's guilt. It should be kept in mind that it's most likely that the donor family could be content that something positive is coming from the death of a loved one. A recommendation is to establish a small relationship, even by email, to maybe get some sense of peace with the family. Now, this isn't for everyone, but in some cases it might work. Commonly, after an invasive procedure, patients are at high risk for chronic depression and start adapting unhealthy behaviors. Many factors that play a role with developing depression could be from possible rejection, feeling that their body isn't good enough to accept the new organ. Something else could be a long recovery time. It could be very brutal for a patient receiving all the immunosuppressants and adapting to a new organ all at once. Also, pharmaceutical adverse effects and lack of support are factors as well. One way to help reduce the risk of depression could be talking to a professional, psychologist, or finding even a local support group.
In this slide, we have outlined the new drugs that we believe that are best for Mr. Smith in this case. As stated previously, tacrolimus and cyclosporin should not be given concurrently to Mr. Smith. Evidence suggests that the superior calcineurin inhibitor for preventing organ rejection and in heart transplant patients is tacrolimus. There are lots of studies that state since tacrolimus was introduced into practice in 1989, it progressively replaced cyclosporin as a primary calcineurin inhibitor after heart transplantations. One of the first prospective randomized studies comparing cyclosporin and tacrolimus after heart transplantation demonstrated both calcineurin inhibitors with the same efficacy and safety, but with a trend to less acute rejections for treatment with tacrolimus. Davis's drug guide states that tacrolimus is frequently taken with mycophenolate mofetil or azathioprine in the treatment for organ rejection, and methylprednisolone interacts with tacrolimus and cyclosporin by increasing serum levels of those drugs. For these reasons, we have decided that Mr. Smith should stop taking methylprednisolone because there are better options with a lower risk. A study proved that there was an improvement in 1-year mortality rates and less acute rejection during the first year after heart transplantation when taking mycophenolate mofetil compared to azathioprine. For these reasons, we have chosen to give Mr. Smith mycophenolate mofetil instead of methylprednisolone. Further research was done proving that tacrolimus is the calcineurin inhibitor of choice to take concurrently with mycophenolate mofetil in the prevention of organ rejection, specifically in heart transplant recipients. For all of the reasons that we have outlined above, we believe that Mr. Smith's medication regime should be changed and he should be prescribed only tacrolimus and mycophenolate mofetil in his immunosuppression therapy.
Action shows the negative impacts that this herb can have on an organ transplant recipient and work in similar manner physiologically as cyclosporine combined with St. John's wort. So it is working on the P-glycoprotein and a hepatic mechanism. According to researchers from the American Society of Clinical Oncology, St. John's wort has been directly linked to 2 patients with heart transplantation failure or rejection. 45 kidney or liver transplant have also experienced an acute rejection after ingesting this herb. The second complementary alternative therapy is Reiki. Reiki is a treatment that uses vibration and subtle energy therapy, which is combined with light touch both on and above a client's body. Those who have practiced Reiki believe that its effects are received from a universal life energy to provide the client with balance and harmony. This life energy is believed to be received from the practitioner through their hands. A Reiki session would normally consist of the client laying on their bed or sitting in a chair where the Reiki practitioner would then come in to place their hands either directly on the client or hovering slightly above in a particular position for 1 to 5 minutes, each for a complete 60-minute session. It is believed to provide healing of symptoms from psychological and physiological conditions. During a large-scale study on the effectiveness of Reiki, it was found that one single session showed improvements with health variables both physically and psychologically, as I mentioned previously. It has shown to be associated with improving an individual's well-being and reduction of pain, stress, anxiety, and depression. Multiple studies have shown other health benefits that include the promotion of healthier behaviors, an improved immune system, and increased social support. Additionally, this practice has shown reasonable evidence that it is more effective than a placebo for healing. 5 different studies indicated that Reiki is better than a placebo for physically relaxing the client, reducing a resting heart rate, and reducing blood pressure. It is also shown to be effective in reducing pain, anxiety, and depression in clients with a chronic illness. Although Reiki cannot completely cure any health condition, it may be used as a complementary therapy alongside other treatments. There is no research on the optimal length or number of sessions, but more sessions is considered to be more beneficial than less, starting with at least 3 sessions. Therefore, there is no harm in Mr. Smith attending a Reiki session, but we must consider the social determinants of health and whether or not he is able to afford these sessions. While this particular topic has still yet to be researched in depth, this is something Mr. Smith can at least try and decide whether or not he believes it will be beneficial and effective for himself.
The third CAM therapy we will be talking about is garlic. Garlic is known for its prevention of hypertension and other cardiovascular diseases. It may be beneficial for Frank Smith as it helps control blood pressure with its vasodilating effects and inhibits platelet aggregation, which may help prevent myocardial infarctions. Since it has antiplatelet, cardioprotective, pro-circulatory, hypolipidemic, anti-cancer, chemoprotective, and immune-boosting effects, it is one of the best foods for preventing disease. A study done on rats proved that fermented garlic can inhibit atherosclerosis and platelet-related cardiovascular disorders, as it enhanced the lipid profile and regulated platelet functions. A contradictory study showed that garlic only lowered blood pressure in patients whose systolic blood pressure values were more than 140. Depending on Mr. Smith's blood pressure, this may or may not be beneficial for his hypertension. Despite this, I would still support Mr. Smith's choice to take garlic supplements, as it has shown to heighten the immune response. Garlic has shown to boost the immune response by enhancing the activity of white blood cells when fighting a virus. Garlic enhances the immune system by controlling cytokine secretion, immunoglobulin production, phagocytosis, and macrophage activation. By controlling these mechanisms, cells such as macrophages, lymphocytes, natural killer cells, dendritic cells, and eosinophils are stimulated. Along with these benefits, garlic has proved to be beneficial when taken with cyclosporine. Severe adverse effects can happen when taking drugs like cyclosporine and tacrolimus, and certain herbal medicines, like garlic, can reduce the toxicity of them. The last CAM therapy is mindfulness meditation. Meditation causes the individual to totally relax, which has many health benefits. Relaxation helps decrease metabolism, lowers blood pressure, and improves heart rate, breathing, and brain waves. Despite what many people may think, meditation is not hard to learn. It is a skill and takes time to learn, but with practice, people can become relaxed quite quickly. Repeating a mantra, such as a word or phrase, or focusing on breathing, is the center of meditation. In one study on how mindfulness meditation and aromatherapy reduce stress and anxiety, participants engaged in various meditation activities and reported how they felt after the experience. The participants focused on breathing and strategies on how to keep the mind focused and closed off to outside thoughts. After these mindfulness activities, the group got together and discussed how they felt after the activity and what effects it had on their anxiety and stress levels. The results of the study showed a 32.9% reduction in stress and a 32.6% reduction in anxiety levels,
and 98.8% of participants experienced less of both. Subjective comments from the participants were very positive regarding the meditation session. Many loved the experience and admitted that it really helped with their anxiety. They also mentioned that they are planning on continuing practicing mindfulness outside the group. The results of the study demonstrate the effectiveness of mindfulness meditation to reduce levels of stress and anxiety. In a second study observing the effect of mindfulness meditation in organ transplant patients specifically, participants practiced meditation at home with audio tapes and kept a diary about their experience. This study focused on how mindfulness meditation played a role in reducing the stress that comes along with organ transplantation. The results showed that the participants experienced better sleep for 6 months after participating in the mindfulness meditation course. Since adequate sleep has been proven to have a positive impact on many things such as mood, health, and well-being, this implies that mindfulness meditation could greatly benefit the health of a transplant patient. Improvements in anxiety and depression were also reported. I would encourage Frank Smith to try meditation if he is interested, as there is a colossal amount of evidence on its effectiveness of alleviating stress and anxiety. Next up, we support him taking garlic to boost his immune system and practicing Reiki along with mindfulness meditation to relieve his anxiety. So we recommend that Mr. Smith follow our recommendations in order to continue a successful organ transplantation post-surgery. After learning in depth about the pathophysiology of the heart transplant, along with the pharmacological drug research recommendations, and finally the complementary and alternative therapies, we have thoroughly established our health plan for Mr. Smith. Of course, throughout the process of making our recommendations, we would work alongside him in a true partnership to provide an informed decision-making process.